Welcome everybody to this journal club on behalf of the Arrhythmia Academy. My name is David Duncker. I'm an electrophysiologist from Hannover, Germany, and it's a pleasure co-chairing this session together with Boris Schmidt. He's an AP from Frankfurt, Germany, and together we are delighted to welcome our guest today. It's Tom de Potter. He leads the EP unit of the Heart Center in Aalst, Belgium, and he's very experienced in new technologies. So the session today will be centered on new technologies for AF ablation, and we will talk about pulsed field ablation, ultralow cryoablation, and the RF balloon. And for the beginning, Tom will give us a short introduction and presentation on these three new technologies. So Tom, the stage is yours.
So thank you very much, David, for the kind introduction. The pleasure is absolutely mutual. It's my particular pleasure to be joined in this session with Boris, who supervised an important part of my training in Hamburg. So it's always a particular privilege to be able to do this. What we will discuss indeed is new PV isolation technologies. And as an introduction, I would like to briefly go over the technological aspect of what it is we'll be showing so that everybody has a grasp of the technologies involved. I just showed my relevant disclosures, and of course, the technology we'll be discussing is still focused on addressing the same clinical problem. The clinical problem did not change over the past 20 years, at least for the purpose of this discussion, for the standardized treatment of paroxysmal atrial fibrillation, which is achieving PV isolation, of course. And to achieve this goal, several new technologies have actually been developed. There's been a multitude of recently or relatively recently released technologies, some of them which even have already been withdrawn from the market after being introduced for a short span. You can broadly divide them into two groups. One group of devices that are specifically suited for one purpose alone, which is PV isolation, the classical single shot devices. And then a group of devices which is also mostly single shot, but can do more than PV isolation. Of course, there is surgery. We won't be discussing surgery. And of course, there is external radiation. Both of them allow very extensive ablation, but we're not going to cover those. But what we are going to cover is DC electroporation and ultra-low temperature cryoablation as technologies for PVI+. Just as a reminder, what is the benchmark? We're competing against. The benchmark today, I think, is still point-by-point RF ablation, which in several trials shows extremely satisfying clinical efficacy. This is a multi-center trial we published last year, the VISTAX trial, a standardized treatment using point-by-point RF ablation, 300 patients, showing an 89% single procedure success rate using conventional monitoring. So that is the clinical benchmark, I think, and that is the benchmark that these technologies should achieve. And single shot ablation is not necessarily new. I said some technologies have been withdrawn already. Here's one example. Single shot has existed for quite some time. This is something I studied when I was in Hamburg, and Boris studied as well. The HIFU ablation that truly provides single shot ablation. You see here a case we published of isolation of the pulmonary veins within 1 second. So achieving single shot, highly efficient ablation is not new. What is new is to do it safely. Most of these technologies have safety issues, not efficacy issues, but safety issues. And apart from that, of course, they are limited by the fact that you can typically only do PV isolation with them. So those, some of them have been withdrawn, for example, HIFU, but fortunately, we have a few recent technological advancements in the space that we will discuss in detail today. The first device or the first technology I would like to show you is RF ablation, but RF ablation tailored so that it becomes a single shot approach by using a balloon, an irrigated balloon, which is the device you see on the top left, that is irrigated, that has these rows of electrodes on the balloon, and it also contains a lumen that allows the diagnostic catheter, a lasso catheter, to go through the balloon and to position itself in the vein to serve both as an anchor as well as a diagnostic tool. The balloon allows customizable energy delivery in contrast to other balloons, for example, in contrast to, for example, the cryo balloon. The RF balloon allows you to ablate a particular region if you choose to do so. And of course, it allows you to customize the energy delivery based on the tissue thickness you expect to find in a particular region. So you can do true single shot, but you can also do segmental type ablation with this technology. This is what it looks like in real life. This is not one of our cases. This case that was shared by the investigators in the SHINE trial. And here you can see the RF balloon sitting in the left superior pulmonary vein, ready to deliver the ablation. You can see the electrograms here on the left side. And now you will see that once ablation comes on, you will see the immediate effect of the RF application on these EGMs. So you can see here, comparing to baseline, which you see on the left, you can see that a few seconds into the ablation, the ablation has succeeded in eliminating PV potentials. You can see the blue lines here, the recordings of the distal lasso, and you can see the baseline on the left. Second technology we'll cover today is ultra-low temperature cryoablation, which is cryoablation using a different energy source, using liquid nitrogen instead of the conventional nitrous oxide that we use in the cryo balloon, which has the distinct advantage of having a much higher energy density. It allows to freeze at much lower temperatures. Of course, boiling point of liquid nitrogen is -200 degrees, give or take, and it allows truly to achieve cryoablation even in the context of circulating water or blood at body temperature. So there is no issue with leaks, for example. We also don't need a balloon with this technology here. You can see running water body temperature over the catheter, and the catheter still manages to freeze this water easily. This is, of course, due to the energy source being used. Ultra-low temperature cryoablation can also be used for things beyond PV isolation. You see examples here of the catheter, which is a linear catheter that gets its shape from a stylet that is inserted. So in this case, a circular stylet is inserted and the catheter becomes a circle, but it doesn't have to be a circular catheter. You can insert a linear stylet, for example, and then the same catheter becomes useful, for example, to treat a flutter with. Here you see an example of flutter ablation, and you can see how we achieve isthmus block and termination of typical flutter within seconds, again in 6 seconds in this particular example. We presented our clinical efficacy using this technology in a pivotal first-in-man study in about 60 patients in the total cohort, and on the right, the persistent AFib cohort, 85% of patients free of atrial fibrillation after one procedure. We presented this early last year at HRS. And then finally, the technology we'll be discussing as a third technology is pulsed field ablation. Pulsed field ablation, of course, most of you have undoubtedly heard, is an extremely promising technology that promises and delivers tissue-specific ablation, meaning we are able to damage myocardial tissue without having to worry about the surrounding tissues, such as the esophagus you see in this illustration, or the phrenic nerve, whereas these structures, of course, would be vulnerable to collateral damage from cryoablation or RF ablation. The mechanism of ablation is direct current application, which causes the cell membranes to leak, which is why it's called electroporation. Another way of describing this technology is non-thermal ablation, because it does not generate significant heat effects. And indeed, the data we have does indicate that it does not affect the phrenic nerve or the esophagus. Here's an example of one particular technology, which is developed by a company called FirePulse, now acquired by Boston, developing a single shot catheter. Again, in the schematic illustration, showing how all these structures that are crucially close to the target tissue can potentially be spared using this technology. And FirePulse has actually advanced the furthest in the field and has presented their 1-year outcome data in 2020 already at HRS, indeed indicating the lack of side effects, most importantly, the lack of these important collateral damage effects, which, for example, were so problematic with earlier single shot technologies. Other platforms exist. I'm just going to show you this last movie. Look at the EGMs in the middle, the PV electrograms. You can look at this movie 100 times or 1,000 times. I still like it. Here's the PFA pulse, and there's the elimination of electrograms. True single shot technology, but this time safe, this time without collateral damage. I'm going to go over this slide. It shows the implementation of one particular platform by J&J. For this technology. We also presented this data at last year's ESC, again, confirming the important acute efficacy goal, but the at least equally important acute safety goal. No side effects, no esophageal lesions, no unexpected adverse events in the post-field ablation group. In conclusion, today in our lab, point by point, RF ablation is still our gold standard. We consider it a gold standard because the clinical efficacy is still very high, 80% single procedure off drugs. We reported 98% if we keep patients on drugs in powder AF, and we have very high efficacy workflows with almost no radiation. But new technologies have been developed that allow very fast, very powerful, and very safe lesion delivery. For example, ultra-low temperature cryoablation or pulsed field ablation, allowing extensive lesion formation in the atrium without concern for collateral damage. So we truly hope, and I truly anticipate that in the next decade, the lesion sets that we have aimed to create for such a long time are finally going to become a realistic goal. So thanks a lot for allowing me to present this. This is the introduction, I guess, to the discussion we want to have. And I'm very curious to hear what you think. And I'm happy to give the word back to you, David, and to Boris.
Yeah, thank you, Tom. That was a really interesting and comprehensive overview of the current new technologies. And I think we all agree that it's very exciting times working in the field of electrophysiology. And I couldn't think of a field in cardiology that has more innovations to present at present. Coming back to your last slide, Tom, of course, you are a very experienced, high volume operator, and with the invention of the closed protocol together with Matthias and you were really standardizing point-by-point RF ablation, making it more reproducible to even less experienced operators. But still, obviously, you're missing something. That is probably one of the drivers why you are looking into new technology. And now, if you look at the three that you presented to us, first, maybe what are you missing with your current approach? Where do you see unmet needs, and what do these, let's say, new technologies cover of your needs, and where do you see the major improvement?
Yeah, those are great questions. So I think, first of all, as you illustrated it today, for the purpose of PV isolation, we're quite happy with our workflow, which is standardized, which is not perfect, but there's no doubt about it. We're happy with what we have. But what is still missing? I think two important aspects. One is scalability and reproducibility of the workflow across centers, especially if you start considering factors in centers that are not necessarily under the operator's control, such as availability of GA, such as the feasibility to do high volume workflows. It typically only works well if you are in a setting where you can do the same thing every day, in and out from morning to evening. And if you are in a setting where that's not a realistic goal, it's not necessarily easy to replicate these high efficacy workflows. And second, of course, is anything beyond PV isolation, except for right-sided flutter, which, by the way, can also be a challenge. But if we want to do linear lesions in the left atrium, it's a challenge. And if we want to do extensive ablations, think about the approaches we studied with dispersion mapping, or with cafe ablation, or with Cox-Maze-like approaches, anything. If you want to do large targets, large areas of substrate, then the focal catheter becomes a very painful instrument. We need an instrument to quickly and safely cover large areas.
Yeah, that's a very good point. And do you think that the, let's say, mapping capabilities of the individual technologies are sufficient to, let's say, analyze and understand those complex arrhythmias before you go for those linear lesions or extrapulmonary vein isolation lesions? Because as I understand, of course, let's say the number of electrodes and the combination of 3D mapping are still scarce, right? That's the limited.
That's a very interesting question. There's two philosophical ways to approach, for example, persistent AFib. Let's focus on persistent AFib for a second. And as you know, and I know you've done this too, one approach, for example, the cryoablation approach, chooses by design not to go into mapping, chooses by design to deploy an anatomical strategy of surgery-like ablation, basically to be a little bit impolite, to destroy as much as possible in a safe way. To do what the surgeons do, the surgeons don't map, they cut and sew. And this is one philosophy. And the other philosophy is, of course, to do targeted mapping and hopefully, ideally, find the one single vulnerable or culprit rotor and ablate that. And with all the studies we've done and all the work we've done, I remain convinced that a subset of patients with persistent AFib is amenable to mapping, and a subset is not. Another subset is much more suited to extensive anatomical debulking, let's say, for the purpose of discussion. What we don't have, or at least what I don't have, is a stratification tool, is a way to figure out who's who before going in. I don't know what you think, Boris. I'm sure you have ideas on anatomical versus mapping guided ablation as well, right?
Yeah, I think first of all, we need to state that in past studies came out with a little disappointing results regarding extrapulmonary vein ablation. Of course, we're talking about the big trials like STAR-AF2 and now DCAF, although not published in a manuscript format, obviously didn't provide the results that we were expecting, that additional ablation provides better results. So we are still behind in understanding where to place our lesions. But I think one aspect of this is also that all these trials in the past were mixed results by missing extra PV targets on the one hand, but also dealing with reconnected pulmonary veins. So I don't know what your experience is when you go for a repeat procedure after a first pulmonary vein isolation procedure. You very often find reconnected pulmonary veins when these patients have been treated in a let's say standard or conventional way. So well, adding lesions on top of your PVI lesions always means that you have two sides of maybe insufficient lesions. And that is where I see a huge potential for these new devices, that striving for durable PVI in a, let's say, almost 100% of PVs treated would bring us into a position where we can investigate extra PV targets again. So what is the value of posterior wall isolation, for example? What is the value of additional lines? What is the value of rotor mapping, etc.? And I think this is, for me, is one of the most interesting aspects of these new technologies.
Yeah, I couldn't agree more. I think finally we will learn what the true value is of PV isolation, because in the past the question was always, did the strategy fail or did the treatment fail? That's absolutely true. Although I have to say, with the technology we use today, it's less common. I mean, you remember when we were in Hamburg, our old boss, Karl-Heinz Cook, published experience on repeat ablations, and they used to go up to 5 redo ablations and the veins would still be reconnected. that's unusual nowadays, to be honest. We do find more patients with veins isolated, but I agree. We finally seem to have the tools to figure out what the true value is of PV isolation, and then the added value of doing something on top, in which so far, as you indicated, did not materialize in the randomized trials.
David, let me ask you one question, since you are the academic guy in our group here. So now that we, as Tom addressed, we are in these new technologies enable a higher rate of reproducibility. So whether this ablation is carried out in Aalst or in any other smaller hospital, probably doesn't come out with, let's say, large differences in at least the acute lesion set. Maybe it takes a little longer, maybe it's not as safe, but again, chronic PV isolation probably will be achieved by other operators too. Does this bring us into a position where we can restudy larger AF trials? Maybe restudy Cabana, where the outcome of an individual ablation was so different from one center to the other? Wouldn't that be a nice idea?
That's a tough question. That's really tough. Resetting Cabana nowadays will not be possible, I'm sure. But it's an important point. And Tom already told us that scalability of the procedure is a very important point. I'm pretty sure that this is important because it tells us about of course, the durability of the lesions, the quality of the procedure itself, the speed, and we are not only talking about strategies, but also about the procedure and how we perform the procedure. And this is probably one aspect we learned a lot from the cryoballoon technique. I think that was one important aspect, to spread the procedure in more centers than only the experienced ones. And the new technologies will aim for the same target. So making the procedure available in more centers and making it safe and effective. And maybe you can comment on this, Tom. Which of those new technologies do you think will be the one that can achieve these goals?
First of all, I have to say, and I want to hear Boris's opinion on this as well. With RF balloon, I have no human experience. So I know Boris does, so I'm very happy to hear his insights on this. But what I can tell you from experience with the other technologies is that I am extremely impressed with the efficacy of ultra-low temperature cryoablation. And I am equally extremely, or perhaps even more, impressed with the safety profile of pulsed field ablation. The efficacy of pulsed field ablation, we still need to wait, but so far there's no real indication that it will be a disappointment. But the acute safety, it's impossible to argue with. We can see application on the phrenic nerve, we can see it contract, it doesn't matter anymore. You're freed of concerns, of a lot of concerns. The posterior wall, you simply don't care anymore. We did all these endoscopies and you see nothing. Also, the patients report no pain next day. There's no pericarditis, no chest pain. The acute safety aspect of pulsed field ablation is one of the most impressive things I've seen. So if the efficacy holds over time, I think it's going to be very hard to compete with. But I'm interested to hear Boris's thought on the balloon and on the other stuff.
Yeah, well, we already had some exposure to the irrigated RF balloon, and I have to say that I'm positively impressed, because my initial concerns when I first saw the device was that RF applied in a circumferential fashion at the pulmonary vein ostia might have a risk or might carry a risk for PV stenosis, and there's the phrenic nerve is very close, and what about the esophagus? It's also close. But I had to learn that none of these complications ever occurred in our lab. So we have performed approximately 55 cases, and we haven't seen a single phrenic nerve palsy. We haven't seen a single PV stenosis, and we have seen only 2 minor esophageal lesions in 42 patients that we scoped after the procedure. So from the safety aspect at this early stage of exposure, I'm really positively impressed. And efficacy is also convincing. So we have a high rate of a single shot pulmonary vein isolation. Navigation is as easy as with any other, let's say, single shot devices. So more or less you have to find the PVs to bring your device where it should be. So I think there's certainly a big, let's say, it will gain a market share in the arena of AF ablation. However, I share Tom's excitement for pulse field ablation or electroporation as an energy source, because I think for this, let's say, procedure, treatment of a non-lethal arrhythmia, the key point is safety. And since there seems to be that, let's say, more or less tissue selectivity or a very low incidence or affection of neighboring tissues, that is certainly the most important point for me, or argument to put a lot of my money on this stock. So I'm pretty sure that this technology will change our way of treating arrhythmias in the future. And well, I think all other engineers, all other companies have already acknowledged this and are going for different devices for developing new vectors for this technology to bring it to tissue. So yeah, regarding the ultra cool cryo temperature device, I think it's also very promising. I think Tom pointed out the direction that maybe creation of linear lesions, debulking, also treating ventricular arrhythmias is certainly a big playground for this technology. And I know that Tom also has some experience with cryo plus PFA with the same device, and the initial data was quite impressive. So yeah, let's grow older and see what the future brings.
True. I couldn't agree more. It's really an exciting time to be alive in EP.
And maybe that's an important point to summarize now. Tom, do you think our final device will be a combination of those technologies?
I think that makes sense. The best device is the device which offers maximum flexibility, maximum efficacy, maximum safety, and many people are trying to make hybrid things, RF PFA, cryo PFA. PFA typically seems to be in the mix, but I think it's reasonable to believe that we will want some degree of flexibility. Yeah.
So we will wait for the Cabana PFA study from Frankfurt. Okay, thank you.
Frankfurt, Hannover, Belgium. Let's do that.
That's for sure. So we will end this session now. Thank you, Boris, for co-hosting this session with me. Thank you, Tom, for giving us your thoughts and some insights in these new technologies. And thank you, the audience, for joining this session. Take care.
Take care. Thank you very much.
Thanks a lot for the invitation.